हेलो हेलो। अरे भाई आवाज किसी तरह का तो आ नहीं रहा।
Sir, meeting starts at 3, sir. A few more minutes.
ओके।
Good.
Babu sir, just to confirm, Suresh sir has joined or not?
Sir, he has not yet joined. We are waiting for him to join.
Okay. Babu sir, you just remove the host control. Sir joining soon.
Yes, sir. Host control has been removed. We can share his screen.
Okay, fine.
Sangeeta
Dr. Suresh Anavadi, sir, have you joined?
Yes, sir.
So, yeah, very good afternoon to you all. I hope my voice is audible. So, thank you. So, once again, we welcome you on behalf of CRC Davanagere, Karnataka, on this wonderful evening on the eve of World Haemophilia Day 2023. So, as a part of our celebrations, and we are going to have a webinar on joint bleeds prevention and rehabilitation. Okay, so our speakers are joining, and today we are going to have a fruitful and informative session on 3 areas. The first one is the medical aspect of the hemophilia management by Dr. Suresh Anavadi, sir. Sir is the founder president of the Karnataka Haemophilia Society in Davanagere, and also sir is a professor in pathology in JJ Medical College, Davanagere, Karnataka. And also followed that we are going to have a rehabilitation aspect, and by Miss Resala, physiotherapist, and is a hemophilia ex-physiotherapist of the Haemophilia Treatment Center all over Kerala. And then we are going to have a government schemes and benefits by our in-house speaker, Sri Kanaka Sabapati sir. Sir is a rehabilitation officer of our CRC Davanagere. So program, the timing is 3 to 6 p.m. Before going to the scientific sessions, I would like to say a few words about our CRC Davanagere. And CRC stands for the Composite Regional Center, and we are for the skill development, rehabilitation, and the empowerment of the person with disabilities. And we are under administrative control of NIPID. So that is National Institute for the Empowerment of the Person with Intellectual Disabilities, Secunderabad, and under the Ministry of Social Justice and Empowerment. And we are dealing with all the 21 types of disabilities. And as I told you, the 3 primary objectives is the skill development, rehabilitation, and the empowerment of person with disabilities. And we have all the facilities, like all the rehabilitation facilities under one roof, like physiotherapy, occupational therapy, special education, psychology, vocational training. So all these are under one roof, and that is the idea behind the establishment of the composite regional centers. We are one of the 21 CRCs established by the government of India under this ministry. So we run courses also in our CRC Davanagere. We run 2 diploma level courses, which is approved by the RCA, Rehabilitation Council of India, in 2 different domains. Diploma in special education in intellectual and developmental disability, and also the diploma in special education in hearing impairment. So it's a 2 years regular courses that we are running. Apart from that, we conduct many programs such as awareness programs and the parent training programs. And also we distribute the assistive devices under the scheme called the ADIP scheme. So this is a brief explanation about our activities, and without taking much time, so I'd like to introduce the today's first scientific session. Today's speaker, Dr. Suresh Ganagwadi sir. Sir is as I told, he's a founder president of the Karnataka Haemophilia Society in Davanagere. And today morning also we had a wonderful session in their premises, and we celebrated the World Haemophilia Day there also. And sir is tirelessly working for the benefit of the person with the hemophilia and all across India. So I hope the sir has joined already, and the sir is one of the eminent person. And without having second thought, we chose sir, Dr. Suresh Ganagwadi sir, as a guest speaker of today's program. And sir is very approachable, as a down to earth, and also so very knowledgeable. And sir runs the Karnataka Haemophilia Society, so that sir will speak about practically. So that's what now needed. As we have the mixed group of participants, like rehabilitation professionals and students, and also the general public. And this program is live on YouTube also, and to reach many beneficiaries and many across India and also the abroad. So without taking much time, and I just invite our guest speaker, Dr. Suresh Ganagwadi sir. I hope the sir has joined already, and to take over the session. Sir, now the screen is yours. You can take over, sir. Thank you. Dr. Suresh Ganagwadi sir, have you joined? I think sir is having some technical issues. You just give us a moment and give us 1 or 2 minutes, and we'll just rectify it, and we'll come back to you. So I think now sir has joined. Very good afternoon, sir. Dr. Suresh, sir. Your mic is muted, sir. You are muted. Yes. Still it is muted, sir. Sir, still it is muted.
Yes.
Yes, sir. Yes, sir. Sir, thanks for your acceptance, sir. Even though you are busy schedule, you accepted our invitation to be a guest speaker.
I will upload my PPT.
Yes, sir. Yes, sir.
See. Entire share. First, yes, now presenting on screen. Stop desktop menu. This one. No. Are you seeing my screen?
Yes, sir.
Hello.
Yes.
Yes, sir.
Okay. Okay. Thank you. Summarize. We can start.
Yes, you can start, sir. You can start.
We can start, no? Yeah, already there. Yeah. I thank CRC NIPIT, and I'm happy that today is a special day for hemophilia community. It is World Hemophilia Day, and we are discussing about hemophilia and its manifestation. Just I will take the medical aspects of hemophilia care. Hemophilia, all of you are aware, it is a genetic bleeding disorder due to deficiency of certain clotting proteins in the blood, and it is second most common hereditary bleeding disorder.
Sorry for
And
the
it also-
interruption, sir. You have PowerPoint, sir?
Yeah, PowerPoint only.
It's a PowerPoint.
You are not
visible.
seeing that? Oh, one second. I thought you were seeing. Now, hello. Are you seeing my presentation?
Yes, it's opening, sir. Yes.
Yeah, I will. Yes. Okay. Hello.
Yes, sir. You can make it full screen, sir. Just click F5.
Yeah, I have made. Okay. Shall I start?
Yes, sir.
Hello.
Yes, sir. You can start, sir. You can start.
Yeah. Hemophilia is a genetic bleeding disorder due to deficiency of certain clotting proteins in the blood, and it is second most common hereditary bleeding disorder. It has got the uniform global prevalence affecting 1 in 10,000 general population. And as it is predominantly male disorder, we also tell 1 in 5,000 male births. And once it was a dreaded disease with no treatment, but due to advancement in the medicine and technology, it is manageable now. And the history of hemophilia is continuously evolving, especially in the evolution of the treatment products. And even we can say we are moving from care to cure. And as gene therapy has shown the positive results, especially in factor IX deficient patients. And Hemophilia Federation India in our country and the 87 plus chapters all over the country working for the welfare of hemophilia, and we are all trying to bring change in the hemophilia care. And just to tell you about the historical aspects, hemophilia symptoms was described in the Talmud in the 5th century, where a woman third son is exempted from circumcision because she lost 2 sons after circumcision. And hemophilia, as you know, it is also popularly known as a royal family disease, because it plagued the royal family. The Queen Victoria was a carrier, and Prince Alexis and a lot of princes and princesses were carried this disease, suffered this disease. And because of this, it is well known in the medical literature as royal family disease. And let us see what is hemophilia, what exactly happens in hemophilia. Before that, let us see normally how bleeding stops. Normally,
Sorry for the interruption once again, sir.
Yes.
Still your PowerPoint is not a full screen, sir.
1 second. One second.
Shall we present from here, sir? We have this PowerPoint. Shall we present from here, if you don't mind?
Okay, I will send it.
Yes.
Sir, it is visible only.
Actually, we are not seeing the PowerPoint. We'll send this PPT to them. I will send it better because
Yes.
I will mail it to you right now.
Okay, sir. Okay, sir.
PPT close ಮಾಡಬೇಕಾ? Tamare, I have sent the mail with attachment.
Okay, sir. To director's mail, sir.
I think Kanaka Sabapati. Director's mail only. Kanaka Sabapati.
Okay, sir. I'll take from him, sir. I'll take from him. I'll take from him.
Google. Ida. Ida. Why it is not share screen? It's a number of in the projector, the window or tab. Your entire screen. Share. Are you seeing now?
Yes, sir.
Yes. Camera cell?
Yes, sir. It is visible, sir.
Visible,
Yes,
no?
sir. But, sir, I will present from here, sir. No problem, sir. We received it. I'm just opening it, sir.
Okay.
I'll
Okay, I
present from
will.
here. I'll present.
Okay.
It's visible, sir. You can continue, sir. You can continue. Now it's
Okay.
visible.
Clear. Thank you. Thank you. Thank you. So, as I was telling you, Yeah. So the how bleeding stops I was discussing. So that is these are the important components of normal hemostasis. The blood vessel, then the platelets and the coagulation system and fibrinolysis also. These are the four important components. And as soon as there is an injury, there will be an immediate vasoconstriction to reduce the amount of blood flow to that part of the area. But it is not, it is a very transient phenomena. It will not help. But by that time, the platelet will rush and form a plug we call primary hemostatic plug. But as the vasoconstriction is transient, platelet plug is a friable, smooth mass which can be filled up very easily in a major blood vessel. It is enough for stopping the bleeding from the minor injuries. So for that reason, we need a coagulation system. In coagulation, there are 13 clotting proteins which act in a cascade. And the main purpose of this cascade is to form the fibrin, thick or strong fibrin, so that it reinforces the platelet plug and stop the bleed permanently. Okay. So whereas in hemophilia, what happens? The blood vessels are normal, the platelets are also normal, but the problem is in the coagulation. Among the 13 clotting protein, any one clotting protein is missed in the line, and that's why that cascade will not continue. If cascade is not continued, there is no fibrin. If there is no fibrin, the platelet plug is not enforced, and hence it is falling repeatedly, and that's why bleeding will be very typical in coagulation disorder, slow, prolonged, but sustained. So there are three types of hemophilia. Most common among them is 2. The factor 8 deficiency, nearly 80% of the patients, and due to factor 8 deficiency, we call classical hemophilia or hemophilia A, around 80%. Whereas hemophilia B, due to factor 9 deficiency, that we call Christmas disease also. It is the name of the patient in whom it was detected. And hemophilia C, very, very rare, factor 11 deficiency. These are the 3, depending upon the factor deficiency, we can classify. And for the sake of discussing the clinical manifestation, we can categorize hemophilia in 3 broad groups. That is one, normally the 50 to 150% of factor level will be there in any healthy individual. Whereas in hemophilia, so the factor may not be there at all. We call severe, less than 1% patients. And these are the patients who bleed repeatedly and spontaneously. Most important, even there may not be any injury, they bleed on their own or spontaneously, and it is repeated. And this is the category where we need to have a lot of challenges in the management. Whereas those patients who are having more than 1% but within 5%, we call moderate category. And these patients may not have spontaneous bleeds, but definitely they bleed on trauma or injuries. And these patients, factor level will be not more than 5%, 1 to 5%. Whereas the third category, we call mild category, where factor level will be more than 5%, but within 30 to 40%. That means they are mild category. This is the category where lot of risk are there, because they may not bleed in their lifetime unless they are exposed to some major challenges like surgery or any road traffic accident. Especially the Muslim families, they undergo ritual circumcision. They may not, the bleeding may not stop after the circumcision. Bleeding may not stop after tooth extraction or any surgery. Bleeding will not stop. So that's why it is the factor level which determines the clinical manifestation of hemophilia. So hemophilia, as told, it is a genetic disorder. To understand this, there are 23 pairs of chromosomes in our each cell. And among them, there is one sex chromosome we call in XY among the male, and 2X, the no Y among the female. So these are the one pair of sex chromosome. We are the main problem in hemophilia because we call it, that's why we call it as X-linked recessive disorder. The gene located on X chromosome necessary to produce this clotting protein is defective in hemophilia, and hence males are affected most commonly because they have only one X chromosome that is affected. So whereas in female, there are two X chromosomes, normal one X chromosome, another one, even if it is defective, the normal chromosome can produce some amount of clotting protein. As I told you, 40-50% is more than enough to stop the bleed. So they don't suffer the bleeding episodes. They can carry the disorder to their next offspring. So here in this scenario, you can see, she is a carrier. We call them carrier. And, when they marry a normal person, and whoever daughter gets her defective chromosome will be carrier. At the same time, whoever daughter gets her normal chromosome may become totally normal. In the same way, whoever boy gets her defective chromosome will be affected. Whoever will get a normal X chromosome from her mother may be absolutely normal. So that means in carriers, there is each pregnancy has got a risk of either having a boy affected with hemophilia or even normal boy, or girl with carriership or normal girl. Okay. So whereas you can see here the affected individual with hemophilia marrying a normal girl. So what will be their offspring? So here there is no chance that his father gives her his defective chromosome. For male, Y chromosome is needed. Any number of, that is, it will never come to the son. Okay, he will never pass it on to the son. Whereas female, so definitely they become carriers. So that's why nowadays, to prevent hemophilia, we do genetic counseling. That is, we can, first of all females in the family of hemophilia need not be carrier. That's why in this scenario, carrier detection is needed. Whereas here, if there is no need of carrier detection, we know that the daughters will be 100% carrier. Here, only straight away we can go for prenatal diagnosis by amniocentesis or chorionic villus biopsy. And if the baby, the fetus carrying the defective gene can be terminated legally. It is legally permitted that pregnancy can be terminated. Okay. So there is a rare situation where in some parts of our country, especially in our North Karnataka, there is rampant consanguinity. Because of consanguinity, there will be marriage between an affected hemophilia patient and with the carrier. That means in our this part of Karnataka, for example, this mother will marry her daughter who is also carrier to her brother who is an hemophilic. So then there is a possibility of getting hemophilia among female, we can call hemophilia. And 30% of patients may not have any bleeding history or history of hemophilia. In that situation, we can attribute it to the spontaneous mutations. That is, spontaneous mutation also is possible in 30% of the patient. From that couple onwards, hemophilia transmits in their families. What are the clinical manifestations? That is prolonged bleeding and trivial trauma. Okay, and characteristic, as I told you, because of the normal platelet plug, they have slow, prolonged, sustained bleeding. And very characteristic feature of coagulation disorder is deep-seated bleeds. They bleed in joints, muscles, and also typical sex incidents and inheritance, which I have described with the family pedigrees. Okay. So this is the most clinical hallmark of hemophilia. They bleed internally, most commonly in the knee joint. They can bleed in any other joints, ankle joint, shoulder joint, and hip joint, elbow joint. So any joint can be affected, but the most weight-bearing joints are ankle and knee joint. Okay, so this is, and also this picture you can see the bleeding because synovium is highly vascularized. That is the reason knee is most commonly affected. And if there is any spurt in the capillary of the synovium, synovial supplying blood vessels, there will be injury and bleeding starts. And since it is a cavity, it goes on accumulating till it causes pressure, and with a tense joint, we call acute hemarthrosis. And these are, you can see, these are some of the people with hemophilia having the knee joint bleed, elbow joint bleed, and they can bleed in muscle, the iliopsoas muscle, the thigh muscle, and with these clinical manifestation, we need to do some lab investigations. I will not go into the detail. That with the typical prolongation of the APTT with some basic coagulation workup, so we can detect whether the patient is suffering with factor 8 or factor 9 deficiency. Okay, and clinically you cannot differentiate factor 8, factor 9. Only laboratory investigation is needed to know whether he has got hemophilia A or B, and if it is A or B, further we need to do factor assay to categorize them into mild, moderate, severe. And the complications, musculoskeletal complications, transfusion transmissible infections, and inhibitor formation. So musculoskeletal complications, I think you generally see, and the transfusion nowadays it has come down because these people require repeated transfusions with the blood and blood products. The TTA, the HIV, HBCG, HCV transmission is possible, and that nowadays 15 to 20% of patients develop antibodies to the factor they keep on receiving in their lifetime. And if inhibitors are formed, antibodies are formed against the factor, then it destroys the factor we give, and the factor becomes totally ineffective, again for exposing us to the challenges of management, because factor 8, which is life-saving, will not work in these patients. We have to go for another modality by using bypassing agents. And since it is a genetic disorder, lifelong disorder, lot of psychosocial issues, which we address by organizing camps and all those. And more than 90% of bleeding episode in patients, they occur, as I told you. And these are the sequence of events if untreated or minimally treated, undertreated patients. So acute hemarthrosis, repeated acute hemarthrosis will irritate the synovium and cause chronic synovitis. And once the further damaging the cartilage and leading to the deforming arthropathy. And these are some of the complications, especially the muscle bleed, which we need to give immediate attention. Otherwise, it becomes a permanent disability. That is, for example, the Volkmann's ischemic contracture, bleeding in the flexor group of muscle. If it is identified immediately and replace the deficient clotting proteins, otherwise these patients will have like foot drop or iliopsoas muscle bleed. These are the muscle bleeds which causes permanent disability. And rarely, some patients may develop pseudotumor. What is pseudotumor? As the name itself suggests, it is not a tumor, but grows like a tumor. So what exactly it is this? So these patients tend to bleed internally. But unfortunately, some patients, if they bleed into the aponeurotic space of the muscle or the bone, what is that? In the subcon, that is pseudotumor. The periosteum of the bone, if they bleed inside, it makes a localized collection and it starts growing. Okay, and there are life-threatening bleeds like intracranial bleed, laryngeal bleed, or even GI bleed and genitourinary bleed, which we need to mention. Since it is incurable, the only remedy is to manage temporarily. What is that management? Replacement therapy is the mainstay in the treatment of hemophilia, and these products are derived from the blood. As I told you, the blood, the what you call plasma derived factors we can tell. So we can, and the recombinant factors are also available because of the by utilizing the recombinant technology. And even in nowadays, though it is derived from the human blood, because of the stringent measures and using the technology of inactivating the viruses, the plasma-derived factors are also equally safer when it is compared with other, that is recombinant factors. Then how to replace these factors? To know this, I ask you to remember that these are the proteins and they have the limited half-life. Factor 8 has got 12 hours, around 8 to 10 hours. We can, for the calculation purpose, we can consider 12 hours, whereas factor 9, little longer half-life, we call 24 hours. Okay, how to calculate? And one more important fact is 1 unit is the amount of factor present in 1 ml of the plasma. So 1 unit factor 8 raises 2%, whereas 1 unit of factor 9 raises only 1%. Keeping this in mind, so we raise the to the required hemostatic level. For example, joint bleed in the low dosage protocol we follow, and this is the WFH guideline, resource restricted. Factor 8, at least 20 to 40% factor level, factor 9, whereas a major hemorrhage, we prefer to raise to the 40 to 50%. Whereas the life-threatening bleed, we prefer to raise the percentage to 70 to 100% in case of factor 8 level. Okay, so these are the factor 8 levels we need to raise during the acute bleed. And there are, to add the recent advances here only, there are some new therapies have come, like non-factor therapy we call, or even we have enhanced factor level. That is, I told 12 hours and 24 hours. Nowadays, we are getting the enhanced half-life factor or long-acting factor by using the technology, or we call pegylated factor. So even you can enhance the factor level so that you can increase the required hemostatic level with, and also you can maintain for the long time. And there are non-blood products used in the treatment of hemophilia. We call epsilon aminocaproic acid, that is gum bleeding and all those we use. Whereas the DDAVP also we use to control the dental bleed. Complications. So as I told you, the bloodborne infection will be there, infections. And as I told you, the auto-antibodies can be formed and they inactivate exogenously administered factor. In such a situation, we have to go for the further quantification of the antibodies before considering these factors in our setup. So what we do Bethesda assay and categorize those who are positive in inhibitor screening into two categories: low titer inhibitor and high titer inhibitor. Those patients who have 5 Bethesda unit, within that we call low titer inhibitor, where we can use factors still, but you have to double the dosage in low titer inhibitor patient. Whereas those patients who are having high titer, that is more than 5 Bethesda unit, any doubling or tripling, it won't help, and we have to go for bypassing drugs. And these bypassing drugs activated prothrombin complexes, and it can be given 50 to 70 units per kg body weight. And another drug is there, that is recombinant activated factor 7. Recombinant activated factor 7. The major challenge is it is a short acting factor. Just half-life is around 3 to 4 hours, not more than that. And the standard dosing is 90 to 120 micrograms per kg body weight for every 3 hours. Okay. And as I told you, one case in Indian scenario, so there are about more than 4 lakh patients in the world, and 25% of these patients are in our side. That is, in India itself, there are about 1 lakh hemophilia patients, and out of that, at least 60,000 will be very severe patients. And now it is around 25,000 patients are registered with our Haemophilia Federation, and it affects all racial groups in the similar way. And hemophilia management is a comprehensive or multidisciplinary approach. We need a physician, pediatrician, we need the orthopedic surgeon, we need physical therapist, we need laboratory personnel, a pathologist and lab technicians. We need nurse. Nurses play a very important role because in fact we call them as nurse coordinator in Western world, because these are the people who coordinate all the care services of hemophilia patients with appropriate specialists. And these patients need psychosocial counseling, and also psychosocial workers are needed, and dentists also needed. So it is a comprehensive team effort in taking care of hemophilia patients. So comprehensive consideration of patient and family, we need to educate, especially psychosocial counseling and collaborative, coordinated education and counseling, and acceptance and adherence and advocacy. Yes, we do for the sake of involving the government and the philanthropists to bring down the bring the change in the scenario of hemophilia care. Okay, so this is how even morning I had an opportunity. I must thank the CRC for giving that opportunity to educate the special workers, diploma in special workers, before I come here. And yes, future hemophilia, primary prophylaxis, we are advocating for prophylaxis. We are advocating for extended half-life factors for their significance. And gene therapy, still we are hoping to get this gene therapy, and inhibitor prediction and treatment with all the technological development, and even prevention of hemophilic arthropathy and viral contamination. So the Haemophilia Federation India has been working along with the 87 chapters, involved mainly in the public awareness, media awareness, education, training of medical and paramedical professionals, advocacy with government, involvement of NHM in hemophilia care has changed the scenario in the last 1 decade, and hemophilia is included under RPD, the revised Disability Act. And formation of women's group and youth group, we promote in our chapters to facilitate them to organize camps, to understand each other, to accept hemophilia in their life, and live uneventfully. And prevention with CD and PND, and networking with corporate and other institutions. And today, it is World Hemophilia Day. We celebrate this day on the mark of birth anniversary of Frank Shanbell, who founded World Federation of Hemophilia in Montreal, Canada in 1963. And as far as our country is concerned, we respect our, we can call them father of Indian hemophilia movement, Mr. Ashok Verma, who himself was an hemophilic and who had the issues and underwent above knee amputation with one knee, one leg. He went around the country and encouraged, empowered the chapters, and that's how we could bring a lot of change. This is just in our this thing. And we have World Federation of Hemophilia link and Hemophilia Federation link, and our chapter in Davangere, Karnataka Hemophilia Society, we have been working with the CRC since its formation in Davangere, and togetherness is always a best model to bring change in these chronic disorders. And to introduce myself, I am Professor of Pathology at JJM Medical College, and more important is I am also a person with hemophilia having factor 9 deficiency, and that is the main reason why I became a doctor, and I have taken up this mission of developing hemophilia care services. And Dr. S.P. Balasubramaniam, a noted playback singer, he helped us a lot in the last 21 years to raise funds, and that's how this is our team in the center. Our vision is hemophilia without disability, children free of pain. Thank you.
Thank you, Dr. Suresh sir, for your wonderful session, even at your busy schedule, for sparing your time with us, and in the interest of the public, in the interest of the person with disabilities, sir. And it was really a wonderful session. And so you just covered major areas of the hemophilia in a short span of time.
Sorry, I have to go. I
hope all the audiences, the participants might have enjoyed that session. And thanks a lot, sir. We are looking forward to have such programs in future with you.
I've always
we are there to support you. Collaboratively, we have a lot to do in the interest of the person with hemophilia, sir. And thanks you, sir. Thanks all the very best, sir. And,
sorry for last minute hiccups, but anyhow, thanks, and I wish all of you a best and happy World Hemophilia Day. Thank you.
Thank you, sir. Thank you, sir. Thanks. It's our pleasure, sir. Thank you. So,
thank you, sir.
So, dear participants, now it's time to move to the next session, and we are having Sri Kanaga Sabapati, sir. Sir is our rehabilitation officer, and sir is going to take about the session on government schemes and benefits for the person with the hemophilia, and that will be followed with the rehabilitation aspect, the prevention and the rehabilitation of the joint bleeds by Dr. Raswa ma'am. Ma'am is a physiotherapist, and ma'am will be joining by 5 o'clock. Now we have a second session by Sri Kanaga Sabapati, sir, our rehabilitation officer. Sir is as I told you, he's a rehabilitation officer of our CRC Davangere, and he has been working in our organization since for the past 6 years. And sir has completed his physiotherapy, Bachelor of Physiotherapy, and then he has completed his MPhil in psychology, and also he has completed his PG diploma in HR management, and he is a national awardee, and he has publications in the national and international level journals. And sir is an asset to the CRC Davangere. He is the most dynamic, one of the dynamic persons, staffs in our CRC Davangere. And I hope the sir has joined already, Sabapati sir. Now I invite our in-house speaker, Sri Kanaga Sabapati sir, to take over the session. Now the screen is yours, sir. You can take it. Thank you. Sir, muted.
Thanks, Dr. Thamare Selvan sir. Thanks, Dr. Suresh Kanavadi sir. Excellent presentation. So very short and crisp, to the point presentation. So I thank at the outset. I thank Dr. Thamare Selvan for organizing this webinar on this special day, World Hemophilia Day. So in this day, the medical aspect is already covered. So now I'm trying to cover the rehabilitation aspect, like how better we can actually rehabilitate the person who is having some difficulty along with the hemophilia. So some or some disability which has been quantified as having disability. Now hemophilia is also approved as a disability as per 2016 RPWD Act. My voice is audible, no?
Yes, sir. Yes, sir.
Yes, sir.
Yeah. Suresh sir.
Yes, sir.
Suppose any issue?
No. Here Suresh sir is also sitting. Little echo is coming. So
Okay.
our Suresh Chandra Kesri sir. And the PPT.
Sabha sir, can we have a host control?
I am sharing it from Nipid only. So host control is not there. I think Nipid admin la I'm trying to share. Is my screen visible?
No, sir.
Your screen is not visible, sir.
Yeah. Trying to share. Samray sir, some issue is there actually. It is not sharing.
Sir?
From the Nipid login only. I'm trying to share.
You're not able to
You must
share your
grant
screen, huh?
permission. Yes, you must grant permission in order to share your screen. Can't share your screen. Like that.
Yes, coming there.
அங்கிருந்து போட்டுறீங்களா ப்ளீஸ்? மெயிலில் இருக்கு.
Suppose I person from here.
Yes, sir. Please.
Give me a minute here.
So medical aspects, Dr. Suresh Nawadi sir has presented very nicely. So now it is a rehabilitation aspect in which government schemes like whatever the schemes available for persons with hemophilia along with other persons with disabilities. That aspect I would like to cover. Next 45 minutes I would like to speak. Once the screen is shared, so you will get to see my PowerPoint. First, I just want to continue from where Sir left actually. So there are three types of hemophilia. Sir has clearly explained that factor 8 deficiency hemophilia A, factor 9 deficiency, that is hemophilia B, and then the factor 11 deficiency, which is very, very rare, that is hemophilia C. See, out of these A, B, C, and 3 types of hemophilia.
Sabha sir, PowerPoint is shared now.
The factor 8 hemophilia, that is hemophilia A. Yes, sir. Please go ahead, sir. Go ahead, changing the slide, sir. Now, second slide, sir. So factor 8 8 deficiency hemophilia, that is hemophilia A, which is 80% common, and remaining are around 20%. So the in an approximate frequency of all three clubbed together, 1 in every 10,000 birth has an estimated frequency of having hemophilia. One in every 10,000 births. So this is actually like Sir has mentioned in his presentation. Hemophilia A has a frequency of 1 in every 5,000. Hemophilia B has a frequency 1 in every 30,000. So on an average, it looks like it's around 1 in every 10,000, as either A, B, C, or one of the hemophilia may occur in 10,000 births. So globally, it is estimated that 4 lakh persons are having hemophilia. So out of that, Sir said, Dr. Suresh Anawadi has presented 1 lakh are estimated to be in India. 1 lakh hemophilics are estimated to be in India. Out of 1 lakh hemophilics who are there in India, now 22,000 are already registered, identified and registered in India. 22,000, approximately somewhere around 20% are detected and registered. The important identification we are lagging here. Participants, kindly mute yourself. The early identification is very, very important. So out of the estimated 1 lakh, out of the estimated 1 lakh hemophilics in India, 80% are only detected and registered. So remaining 80% are yet to be detected and registered. So it is a very tough situation actually. Though the care is available across all district hospitals, all blood banks are available to give actually supply the factor blood component, that factor 8, 9, and 11. So but still it is rampant that like we are not even able to detect the estimated number of persons with the hemophilia. So important aspect is we need to take care of diagnosing, and we need to take care of diagnosing the hemophilics. The severity, Sarah has explained very clearly. The normal range of the clotting factor which is needed is actually like 50 to 150%. So, but in the severe category, the clotting factors go down to less than 1% in the severe category. In the moderate category, 1 to 5% the clotting factor, but normal range is 50 to 150%, which is normally available in the human body of any non-hemophilic human body. So, which I have shown in the call out, cloud call out. Normal range is 50 to 150%. But unfortunately, like with the hemophilia affected person, it is ranging less than 40%, sometimes less than 1% also. Less than 1% is very severe category, and they used to get bleeds once in a week, approximately once in a week, or at least twice in a month. So moderately classified person having hemophilic, having the clotting factor 1% to 5%, and which is expected to get a bleed, episodes of bleeding 4 to in a year. That is every 2 months or 3 months, they will get one episode of bleeding. So mild category, like bleeding episode is uncommon, and the bleeding happens only at the major trauma or surgery, major accident or major surgery. So this is a classification. Now, why I am stressing upon this classification is actually there is a link connected with this classification with the disability type. So if we go to the next slide, gives the overview. So the disability score against the factor availability. So if the factor availability is more than 5%, then the disability score will be 10 to 20%. As per Government of India classification, disability grading, we have the guideline which is issued by Ministry of Social Justice, Department of Empowerment of Persons with Disabilities in the year 2018. After 2016 Act has been passed, the guideline is released, and as per the guideline, disability grading guideline, factor level more than 5% are expected to get disability score 10 to 20%. So factor level 1 to 5% are expected to get disability score 21 to 39%. We all know that this percentage of disability less than 40% is not considered as benchmark disability. And if they are given a certificate having disability less than 40%, they may not be eligible to get any government scheme. Many of the government schemes, which a minimum percentage of disability as 40 or above. So those who have factor level between 1% to 5% or up to 40% having hemophilia may not be actually like directly eligible to get a disability certificate with 40%. They get the bleed and all, but still they are not getting the entitlement to be disabled. So I Government of India disability grading. So Nancy, please keep your mic mute. Nancy. Yeah, kindly cooperate with us. Actually, like our time is very less, and we want to cover the entire presentation. Around 40 more slides to go. Please keep your mic in mute mode. Cooperate with us. Yeah. The score is more than 40% if the factor availability is less than 1%. And then it goes actually with the clinical severity. Clinical severity, symptomatic with 2 bleeds, with the limitations of joint movement and all, like assessed by orthopedician and physiatrist. So then 40% and above disability can be given. So here this is important aspect which we need to know. Now with this criteria in Karnataka, how many people have registered in UDID database and how many have received UDID certificate? So as on today, 2,746 persons are registered, and out of them 1,182 have received their UDID certificate. In this also another 31 have received their certificate with less than 40% as their disability. So ranging from 1% to 39%, 31 people have received their UDID certificate. So approximately like 1,151 exactly that many people have received UDID certificate having hemophilia as a disability as on today in Karnataka. So this needs to be seen. Like these people, 1,151 people will only be eligible to get disability related scheme benefits. So those who have not received the disability certificate are not entitled to get disability related benefits. So as a rehabilitation professional, the first point we need to focus is we need to ensure all the people having hemophilia, suspects of hemophilia, first to get registered in the UDID database. So which is a self-registration portal. Anybody who has mobile phone having some data pack, 1 GB data or 1.5 GB data, like it is very easy to actually register in the website. It is swalambancard.gov.in website. So with a photograph, with a photo and the other information, the registration in the UDID database can be easily done. So once the registration is done, the registration document need to be printed and taken to the medical board. District medical board assess the validity of the disability information and they grant the certification. So if the certification is granted with 40% or above 40% as disability, then the person is entitled to get scheme benefits like persons having hemophilia or having disability or really having a challenge in the environment in accessing different clotting factors. Actually, like clotting factors need to be provided, distributed by the government, but most of the time, like in the district hospitals, it is not happening actually in a very systematic manner. People have difficulty in accessing the clotting factors. So the clotting factor distribution is actually irrespective of 20%. Like disability clotting factors having available for them. It is available for them in a having disability is really actually like result their educational prospects, their employment opportunities are to like inability to participate in the economic activity. So disabled are more so as said. Let us go to the next, sir. Yes, sir. So disability and poverty are very closely linked. Both are having a vicious cycle. Very closely linked. Having disability is actually more prone to attract poverty, and people have poor background are likely to get disability very often. So both are very closely linked, and it's a vicious cycle. So the schemes are designed to break the cycle. Government schemes are usually designed in a very kind of targeted manner to proportionately address the poor people to actually liberate them from the poverty. So why targeted interventions benefiting persons with disabilities are being planned? Because they are more prone to get poverty, like if they are disabled, including persons affected by hemophilia also falls under the same category. So repeated governments, every government is coming and announcing different schemes in different categories. Let us go to the next slide, sir. Magnitude of the disability. So globally, WHO estimated that more than 100 crore people at least one type of disability, which is the global estimator. So out of this 100 crore people, approximately 4 lakh people have hemophilia. That is a global estimator. In India, as per census 2011, 2.68 crore persons with disabilities are there, which is roughly 2.21% of the Indian population. So this is a very outdated census. Now, after this census, 2016 RPWD Act has come, wherein in the 2011 census only 8 disability were enumerated. Now in 16 Act, 21 type of disability, including hemophilia, is added. So with this, the number of persons with disabilities in India would have actually jumped triple fold or 5-fold, actually, ranging from 3 to 5 times. So national survey conducted in 2002 also revealed that like approximately 4% of rural households has at least one disabled person in their home, are in the employable age, with the age range from 15 to 59 years. And out of that, 99 lakh people are either non-employed or marginal workers. So huge gap is there actually. 1.34 are in the employable age range, and only 99 lakh persons with disabilities are employable but not employed. So huge gap is there actually. So we need to do a lot of work to bridge the gap. Next slide, sir. Literacy gap is actually like between the disabled and non-disabled. It is 8% is the gap. So all India population, 63% is the literacy status as per 2011 census. And among the PWD persons with the disabilities population, it is 5%. So there is a gap of 8%. So which we need to address. In Karnataka, it is again the same around 8%, but still it is Karnataka state is doing better than the all India average. 67% of all population are literate, and 59% among the PWD population is literate. And next slide, please. About the working group, who are all workers. And census has a very broad definition for differentiating workers with non-worker. So with that, of actually like a broad definition of worker. So the census has been calculated. Even a person who is employed for a season, a rainy season, some 15 days in a season, they are also considered as work. When somebody is receiving stipend and getting training, they are also considered as workers. So very lenient way of calculating, accommodating all people as workers. So with that definition also, let us go to the next slide. So how many people are working? So across India, among all 40% is working. So among the persons with disability population, it is 36%. So 4% gap between the all population and person with disability population. So in Karnataka also like the gap is there, which is wider than the all India gap. All India it is only 4% gap. Here it is 8% gap is there. Among all population, it is 46% are reported as working, and among person with disability population, it is 38%. The gap is little wider, not little wider, double in Karnataka. So we need to work more in Karnataka to bridge the gap. So UDAD status as on 29 March 2022 is this is the latest published document by Government of India. So approximately 40% of the UDAD card. We have seen actually from the estimate there are 1 lakh hemophilia affected people are there in India. Out of them, only 22,000 have been diagnosed. The award has presented that factor. So only 20% here in overall, or between census 2011 and between census 2011 and the UDAD card issuance, only 40% is the coverage. So this is the first C5 and certify a person with a disability. This is the first step. So certification is the first step. Once the certificate is received, then using the certificate only, all is possible. Either it is transport support, or it is social security pension support, or railway pass, or like a scholarship support based on disability. Whatever support available from government, all benefits are possible like only after getting the disability certification done. Disability certification with disability percentage more than 40%. That is the benchmark disability as per 2016 Act, 2016 Rights of Persons with a Disability Act. So considering that this is a very important step, all of us rehabilitation professionals involved in rehabilitating persons with disabilities need to take care of actually like enabling the person with hemophilia, enabling the person with any disability to get themselves registered in the website, in the swalampancard.gov.in website, and get themselves assessed by the medical board. Medical district level hospital medical boards are available to certify the people with disability. So UDID need to be facilitated. UDID need to be bridged. 100% coverage need to be done. So we all are living in the digital world. Now we all have mobile phone in our hand. We all have actually WhatsApp, Facebook.
Sabha sir, I think your voice is breaking. Can you come and present from here, sir?
Sorry for the interruption. A little bit technical issue. Now it is sorted out. So UDID is a very important yeah. Am I audible now?
Audible, sir, audible.
Yes, sir. Yes, sir.
Okay. So we need to focus on the UDID data of all disabled, including persons with hemophilic also. So which is only 20% as per Dr. Suresh Nawadi's presentation and my presentation. So we need to work and we need to ensure that the UDID database coverage is enhanced, maximized to the best possible level. So disability laws in India. The Mental Health Care Act is there, 2017 it has come. Rights of Persons with Disability Act 2016 it has come. So Rehabilitation Council of India Act in 1992 it has come. So National Trust Act it has come in 1999. United Nations Convention, all these acts are stemming from the UNCRPD, United Nations Convention on the Rights of Persons with Disability. So which was signed by India in the year 2007. In the year 2007. So in this actually in 2016 Act, hemophilia has been included in the disability, legally approved disability in India. So in since 2016, there are several steps taken by Government of India. Now certification procedure guidelines are issued. Now UDID database, several people are getting their registration and getting certificates. Earlier that facility was not available. and there are several schemes available for persons with disabilities. So the schemes are done in major domains. There are health schemes available, education schemes available, livelihood schemes available, social schemes and empowerment schemes are available. So CBR guidelines published by WHO in the year 2010, in resource limited settings, actually like we implement our activity, rehabilitation activity with the community perspective, because that is only the feasible model to reach mass people, to reach thousands and lakhs of people with the services. So several schemes are being actually like implemented. Let us see few of the schemes. So with all the schemes, government is trying to provide support, guidance, and training facility so that people's potential can be maximized and they can participate economically, live a productive, meaningful life. They can live a independent life at their best possible potential. So that is the ultimate aim. So here in this photograph, there are two persons. One person is actually doing daily wage work without even having both the arms. So there is a support system. So he is able to actually like do the hardcore work. Another person below, Mr. Divyanshu Nyanendra. So person who is having full blindedness. Also, he is an advocate, paraglider, and he works as a successful professional, as a lawyer. So paraglider, he is the first visually challenged person flying solo in the paragliding sport. So paragliding is a sport actually jumping from the cliff, hill mountain, and then landing in the sea. So it's a very adventurous sport. So without having eyesight, like taking up this sport is also possible, provided appropriate guidance, support, encouragement are given actually. The government is trying to provide different schemes which are all actually aimed at providing appropriate guidance and training to the persons with disabilities. So support to the persons with disabilities so that their empowerment can really happen. So let us see few of the schemes. In health scheme, factor 8, 9 and 11 factor are required for hemophilia patients. Like each unit of factor costs some amount actually, like minimum of 250 units to 1500 units may need to be given actually. So depending on their body weight, which need to be given. So one time the cost for the treatment would be somewhere around 1000 to somewhere around 40,000, 50,000. So it ranges actually, like depends upon the severity, mild, moderate, and severe. So the factors need and then the requirement of the factor in proportion. It depends, but these factors are freely available in the district hospitals, in the medical college hospital blood bank, and also in the district government hospitals. Often to reach the hospital in the right time and then get the transfusion done for the factors or challenging factors. So from a news, actually, I just go through some articles. I came across approximately 20 to 30% people only can have the access in the right time. So they report actually like very late in the hospital. They report in the untime in the hospital where the blood bank is actually like blood banks usually very few blood banks actually like will be fully operational 24/7. Like these things may need like there are operational difficulties and reaching the hospital in the right time. Earlier time is not happening. So only 20 to 30% are reaching, remaining are getting delayed. And though it is available in the district hospital, at times the stock out is being reported. At times actually like the enough quantity is not available. So like different factors are there. Even after reaching the hospital, also the factor distribution is not appropriately happening. So all these factors need to be sorted out with some advocacy, with some resource provision in the hospital level. So those who have disability along with hemophilia, if they get to have the bleed in the joint, they get physical disability. If they get to have bleeds in the eyes, they get visual disability. If they get bleeds in the inner ear and all, now they get hearing disability. So ADIP scheme is a scheme where assistive devices are being distributed by Government of India at free of cost for all the poor people. So person need to have a disability certificate with 40% as disability and need to have valid citizenship card, that is either Aadhaar card or voter ID or any proof to show person is a citizen of India. Having disability card with 40% and having identity card as Indian, Aadhaar card would do, and then having proof for income. So either income certificate or BPL card. So income certificate with income less than 22,500 per month. So approximately this comes around 2.5 lakh per year. So like 22,500 is the monthly ceiling limit which is kept. So passport size photo, 2 photos need to be given. Now in online also the scheme application is available. Anybody having internet, they can type Arjun portal for free assistive device. So Government of India has opened this Arjun portal before some 7-8 months. Now it is in full-fledged functioning. So they can choose their distributing agency and they can choose the device which they want. Persons having disability can register themselves in the Arjun portal. Participants kindly keep your mic mute mode. Participants kindly keep your mic mute mode.
காலையிலே போறோம் நான் காக்னிட்டிவ் தூக்கிட்டே லைவ்
Somebody is speaking in Tamil, so please keep your mic in mute mode. Thank you. So this Arjun portal registration is available in online, and with that registration, anybody across India needing any device having disability 40% can register their information in the Arjun portal. So in the Arjun portal, if they register, they can choose what type of device they want: crutch, wheelchair, hearing aid, smart cane, whatever type like which they want as per their disability requirement. They can choose, and they can choose the institute which they want to apply for. They can ask for Alimco, which is one of the major Government of India's production corporation. So, or they can choose here CRC Davangere or CRC Bhopal, whichever organization nearby to them. There are 21 CRCs across the country, and which is listed, and there are some 9 national institutes across the country. National Institute for Empowerment of Persons with Intellectual Disability, that is one of the pioneering institute available for distributing teaching learning materials. Anybody having requirement for teaching learning materials, they can choose the National Institute for Empowerment of Persons with Intellectual Disability, Secunderabad. For hearing instruments like hearing AOJ, NHS in Mumbai, actually they can select that organization. For visual related institution, it is Visual Disability Specialist Organization is the National Institute in Dehradun. So depending upon the disability type, they can choose what device they want and which institute they would like to apply for. All these things are available to choose in online. It is Arjun portal, ARJUN portal. Arjun portal available in the Department of Empowerment of Persons with Disabilities website. So they only information needed is actually photo, UDID certificate, and the income certificate. These 3 are the minimum required information. The documents need to be scanned, uploaded, and submitted. Once it is submitted, it is the onus lies on the government organization, so to which the submission has been done. So the onus lies on either with the CRC or with the National Institute to actually order the instrument and supply it in time. So this is our building, actually, like some of the happy people, those who are receiving teaching learning material, and different devices are happily taking and going. So status of implementation of the ADIP scheme by the ministry. So this assistive device distribution scheme is named as ADIP scheme, and since the year 2014-15 to 2021-22, since the year 2014-15 to 2021-22, we see 100 crore to 200 crore is the approximate amount allotted, and approximately 2 lakh to 3 lakh persons. Approximately 2 lakh to 3 lakh persons are getting benefited. So this much volume of money government spends, and this many number of people are getting benefited in every subsequent year. So this is actually like happening every year, and now it is going to be increased few folds, because now the online availability is also there, online registration availability is also there. Anybody who is finding it difficult to register by themselves, they can approach the citizen center, actually, like common service center, citizen centric computer center. In Karnataka, there are several centers. Karnataka 1, Grama 1, in Davangere, in the name of Davangere itself it is there. Davangere 1, like Seva Sindhu portal, different names. The e-service centers are available, which is being franchised and given to the private people to implement for the sake of public's benefit. Many government schemes, including this ADIP scheme registration, is also possible through the e-service centers. E-service centers are available across all the places in Karnataka. At least every Gram Panchayat has one e-service center. So in that e-service center, now this registration for ADIP scheme is also possible. Only the thing is actually the information, the document of Aadhaar card, document of UDID certificate, and the income certificate are needed. So these three documents are available with the photo, scanning, uploading, and then submitting the required information. Now this scheme is actually going to increase in reach. So and if the demand is more, government definitely wants to supply, because any government, whoever comes to power, they would like to actually see person with disability as the most deserving deprived people. They want to really support actually. So whatever application comes across will be honored if the appropriate supported documents are given. So this is a very good scheme government implements, and we need to make use of this scheme. So for visually impaired, there are 84 devices are available. For leprosy affected people, 46 devices are available. For intellectual disabled and multiple disabilities, 72 different devices are available. So for the intellectual disabilities and all, like the kits are, in each kit, like around 20 items are being clubbed and then given actually. Like it is a package of learning devices. For visual impairment also same thing, like braille kit. So which has the kit has different items inside to learn actually. There will be a slate, there will be a writing instrument, there will be a calculating instrument. So braille kit has several instruments inside actually. So like that, like though it is looking like 84 items, so in each kit some 10, 15, 20 items are distributed together. So it is not needed to be actually applied separately. They need to give their information correctly. Background information need to be given correctly. They are studying so and so class, and this is their age, and this is their information, and they want this kit. So based on their age, like it is decided finally and distributed. For hearing impaired, besides the cochlear implant surgery, there are 32 devices are available actually, like to be distributed freely. Orthopedically impaired, 268 devices, wheelchair, tricycle, cane, different orthosis, prosthesis. So there are 268 items are available. So education schemes, government gives scholarships, government provides support for writing exam, transport support, loan support with less interest or with waived of interest, skill development programs. So many programs are available. Let us see one after another. So scholarship scheme is there, pre-matric scholarship. So for the class 9th standard and 10th standard. So those who have the income, family income less than 2.5 lakh per annum, the pre-matric scholarship is applicable. Approximately 20,000 scholarships are awarded per year for persons with disabilities. Usually the announcement comes in the month of July and the last date is given August or October. But last year it was extended up to December. Some of the schemes are extended up to January also. Application date were extended. Even then, like they found actually like the number of applicants coming and asking for the scholarship, it is relatively less. The website is scholarships.gov.in. Through that website only, like all scholarships are now distributed for minority, for scheduled caste category, for scheduled tribe category, for the migrant workers, informal laborers. Scholarships of different category are there. All the category of scholarships are available in the website scholarships.gov.in, Government of India's scholarship website. So it's also called national scholarship. For the pre-matric applicant, successfully if they are awarded a scholarship, approximately 10,000 to 12,000 will be the amount, approximate amount in a year they get. So post-matric scholarship, we are facilitating the scholarship application from ERC Davangere. Approximately every year we support around 100 people. We know the volume of the amount, like how much the government grants in each type of scholarship. So post-matric scholarship, please keep your mic in mute mode, cooperate with us. Another 10-15 minutes, the presentation will be over and next session will be done by the physiotherapist. So participants, kindly cooperate with us, keep your mic in mute mode. I request our administration to, like, if the person is not cooperating, please remove them from the meeting. Yes. Sir, administration, Surendra Babu sir, please take care. Scholarship approximately like 20,000 to 1.5 lakhs it has been received. So post-matric scholarship for any qualification above 10th standard, pre-degree first year, pre-degree second year in Karnataka, in Tamil Nadu and all 11th standard, 12th standard, or diploma course or polytechnic course, or any graduation, post-graduation, all those qualifications are qualifying educational people are like eligible to apply under post-matric category. So post-matric, the amount, approximate amount of scholarship which is expected to be received is approximately 20,000 to 1.5 lakh. So 17,000 persons can receive this scholarship. 17,000 persons having disability in India can receive this scholarship. So mostly these scholarships are available from the month of July. This portal is open and up to October it will be available. So in rare cases it is extended beyond October also. Last 2-3 years it was extended because of COVID and COVID's impact and all. So scholarship for top class education. So IIT, IIM, institutes like AIMS, so they are classified as top class education providing institution, and those institutions can actually like they are charging the candidates to pay some good amount of fees. Recently I came across to one of the IIT student, so he's been charged 2.5 lakh per annum is the tuition fees. So he is a person having visual impairment, came to us, applied through our scholarship, this national scholarship portal, and got sanctioned that amount actually, like 2.5 lakh can be claimed under this category. So top class education, the maximum ceiling of scholarship is 2.5 lakh. Eligibility to apply parental income ceiling is 6 lakh per annum. So earlier two scholarships, the family income limit is 2.5 lakh only. This top class education, the income ceiling is raised to 6 lakh, and the amount expected to be received is approximately somewhere around 1 lakh to 2.5 lakh. Maximum ceiling is 2.5 lakh. So this is about the three different types of scholarships. Overseas scholarship, fellowship, free coaching, facilities are also available. The overseas scholarship actually any person with a disability wants to pursue higher education, not in India, want to go to abroad. So meritoriously, if they are selected, so they are given scholarship. Scholarship worth approximately 10 lakhs to 15 lakhs. Approximately 10 lakhs to 15 lakhs per annum. So throughout the year, this portal is open. So recently it is opened. It is available in the Ministry of Social Justice and Empowerment website. The portal is available in the Ministry of Social Justice and Empowerment website. National Fellowship, UGC sponsored fellowship. So whenever the application is invited by UGC, it is given. So monthly scholarship, this is for the people who are willing to pursue MPhil or PhD. So the ceiling, income ceiling is not given. The amount which they can get for pursuing higher education is 31,000 per month for first 2 years, and then 35,000 per month for next 3 years for the PhD students. So it is for 5 years they can receive the scholarship. So free coaching service is also available. Free coaching service is also available for 2,000 persons with disabilities. Those who wants to prepare for railway exam, bank exam, or UPSC exam, or KPSC, TNPSC. So Public Service Commission exam, Staff Selection Commission exam. So different exams are there, competition exam. So those who want to pursue for a period of 2 years, they can undergo training, and the coaching support is being given by the government. 2,000 people can take this support. Monthly stipend will be given. Allowance will also be given, and the coaching fees also will be paid to the institute. There are several institutes empaneled to be given free coaching. So some of the institutes' name are listed here: Career Plus Educational Society, Bandipora College of Information and Technology, Sachdeva College Limited, etc. All these informations are available in the DEPWD website, Department of Empowerment of Persons with Disabilities website. So Rehabilitation Council of India Act 1992. So RCA has been formed to regulate the training and the programs available for rehabilitating people with disabilities. So in India, the RCA is formed to establish standards for the training programs, for the diploma courses, for the bachelor courses, involved in producing rehabilitation professionals. So course curriculum, evaluation standard. So all these things are set up by the Rehabilitation Council. They recognize the institution, they supervise the institution, they supervise the curriculum, they supervise the exam, they ensure that people with appropriate qualification are being enrolled and trained appropriately, and with necessary skills, with necessary competency needed for providing rehabilitation are being groomed. So that has been ensured by the Rehabilitation Council of India. So status of Rehabilitation Council of India's implementation. So more than 1.6 lakh professionals were registered in the Central Rehabilitation Register. Anybody wants to search for any speech therapist, any occupational therapist, any physiotherapist and occupational therapist, any early intervention specialist, any special educator. So Rehabilitation Council approved professionals. 16 categories of professionals are there. All these category of professionals can get a Central Rehabilitation Register number, CRR number. So, and those people information are available in the RCA website. Anybody who wants rehabilitation service can access the information, and then they can get the address, contact number of the professional. 1.6 lakh professionals are presently registered and available in the CRR database. So there are 60 courses operational through regular mode, and training 16 category of rehabilitation professionals. More than 600 institutions and 14 state and open universities run RCA affiliated courses. So transport support is being actually given in Karnataka. It is free bus pass for blind people through through online portal only it is being distributed. Application need to be done, and then the document need to be produced to the district KSRTC government office, government state transport office, and wherein actually the document will be verified and they will be issued free travel pass. For fully blind persons it is free, and for 40% and more disabled visual impairment and other disability, per year 660 rupees is the charge they need to pay, and they are allowed to travel 100 kilometer freely in Karnataka. So different states have different provisions. So in Karnataka, it is free bus pass for totally blind person, and annual fees of 660 for other disabled person, including visual impairment having less than 100%, like they fall under visual impairment. So and other category of disabled people having 40% and above disability, it is 660 rupees annual fees need to be paid, and they can travel freely in a radius of 100 kilometers. Train pass is also been available actually, like having different disabilities. So the concession available is actually sometimes it is 25% or sometimes up to 75%. So in each important railway station, the application for train pass can be given, and the application of train pass need to be in the specified format. Railway has published the format. In that format, application need to be submitted. It is ascertained by the medical board. Once again, medical board need to certify with the name of the registered medical doctor, with the registered number, with the details of disability, everything written, it need to be submitted. So along with the concession certificate, the presently issued UDID certificate and the ID card, so proof for date of birth, proof for residence, photo identity proof, and color passport size photograph all need to be submitted to the senior divisional commercial manager. Like through the nearby railway station, it can be submitted to the divisional manager, and an inquiry will be done by the railway, and they will issue the railway pass, which is usually valid for 5 years. And for some categories now, it is lifelong validity certificate is also been given. So they have established norms against the norms. Few categories it is lifelong, but for few categories it is actually like 5 years once it need to be renewed. For getting the railway pass, there is no fees. Once the railway pass is received, for getting the railway ticket at the time of booking, it is 25% to 75% concession is available. So loans for education, for self-employment. So there are several loan scheme is also available. So we know Mudra loan is available. So Vidya Sri educational loan is available. Vidya Lakshmi educational loan. NHFDC loan is available. So many loans are available with a nominal interest rate, and some special subsidies are also being given. Different state government follows different rules. So NHFDC follows 1% rebate in the interest for women with disabilities and person with disabilities other than orthopedic handicapped. So schemes are available. We need to be aware of it, and we need to apply for it actually. So skill development programs, foundational skill development, technical, vocational, professional skill development, business skill development, core life skill development. So different schemes are there. So there was a target set. 1 crore youth need to be trained within 2020 from 2016. Some good amount was also been allocated. So with that aim, Prime Minister Kaushal Vikas Yojana. So skill development training program was actually started. So PM, participants keep your mic in mute mode. Participants kindly keep your mic in mute mode. So as on date, this is PMKVY 3 round 3 la. So 24 lakh people were placed out of out of 1.5 crore enrolled candidates. So like there are two recently also I have updated it as on 17th April. So 1.5 crore, 1.42 crore were enrolled. Out of them, 1.24 crore were been assessed. So approximately the target which was set was approximately crossed. But however, that target was for non-disabled or for all people, including disabled. But for disabled, the target set is different actually. So another separate target was set as per National Action Plan. 25 lakh persons with disabilities need to be trained by 2022. But as on today, I was checking in the website, only 15 lakh people have been placed. Approximately 1.5 lakh were been trained. 1.5 lakh were been trained, and 15,000 only were been placed. So a target of actually like achieving 25 lakh person with disabilities training is very underachieved, and government is giving much push. So many of us are working in the special education institution or rehabilitation environment. So we all have a scope to apply for skill development training programs in the Skill Council for Persons with Disabilities. So scpwd.in, in the website you go through it, and you also become one of the training partner and start providing training for the persons with disabilities in different trades. There are several trades were approved. So qualification tax or national occupational standards aligned are 223 trade. From the last, the second one in your right side, if you see 223 different trades are aligned for persons with disabilities. 3 months to 6 months programs are available. Either it is tailoring training or small data entry operator training or paper plate make training. Different trades level it is being approved. 3 months to 6 months, and all are giving actually very good scope for persons with disability to get empowered, start some self-employment activity or get some wage employment. We need to be aware of it and where to access the information. So in my district, where it is available. So in Davangere, it is Ruman Technologies Private Limited. They are there near Bhagirath Circle in Davangere. So information is available in Google. Like we need to just browse it and get the information. So many livelihood schemes are also available. Livelihood schemes, disability pension. There is a concession reservation in the job. Different schemes for social upliftment of persons with disabilities is also available. Sugamya Bharat scheme, Smart City scheme is also available. So list of government vacancies. So from this website it is available. Different ministries have earmarked vacancies, which is supposed to be given only for persons with disabilities, and that vacancies information is available. Thousands of vacancies are available. The thing is actually people with disabilities with the required background, with the required category of disability are not really showing up to appear for the exam and cracking the exam and getting the job. The backlog vacancies are thousands, and all the informations are available in the Office of the Chief Commissioner of Persons with Disabilities website. So by anybody who studied after 8th class, 10th class, they need to register themselves in the employment exchanges. Ministry of Labour and Employment has established several employment exchanges across India. At least every district has one employment exchange. There are several special employment exchanges are also available. So we need to identify whichever the special employment exchanges available near to us. Enable the person with disability those who have completed at least 10th standard or PUC, first year, second year, ITI, Polytechnic, to get themselves enrolled in the employment exchange, and they appear for the local interview. Actually, local government sector opportunities, they are being recruited through the employment exchanges. So we need to enable that. Social disability pension. So in government of Karnataka, so monthly pension for 40% to 75%, it is 800 rupees. 40% to 75% disability, any disabled can get 800 rupees monthly pension. For more than 75% of disability, it is 1,400 rupees per month. For intellectual disabilities having 75% or more than 75%, it is 2,000 rupees per month. So different state government has different schemes. So let us ensure that our person with a disability, including person having hemophilia, are being actually registered for the social pension system, and then they get the monthly entitlement. It comes to their bank account or post office savings account in every month. The government distributes in a monthly manner. Special provisions are there. 4% is the job reserved for persons with disabilities, and 5% is reserved for poverty alleviation schemes. So different schemes who are actually interested now, like poverty alleviation schemes, agro land distribution scheme, housing scheme, toilet constructing scheme, or distribution of milk animals, goats, cows. So different schemes are there. Distribution of tractor. So any poverty alleviation scheme which has been actually implemented, that poverty alleviation scheme need to have 5% reservation. Housing scheme, Prime Minister Awas Yojana. Earlier it was actually Indira Gandhi Awas Yojana, like that it was there. So now it is Prime Minister Awas Yojana. And all these Awas Yojana are government schemes whichever designed for poverty alleviation. 5% internal reservation need to be followed for persons with disabilities. And we need to ensure that our person with disability, including hemophilia affected people, are applying for such schemes.
Sabha sir, sorry for the interruption. How long it take, sir? How many slides more?
Almost finished, sir. Final.
Okay.
Yes, sir. So this is the summary. So let us work together for the realization of the entitlement of RPD Act provisions, which was enacted in 2016. 5% education reservation is available. 4% employment reservation is available. 5% reservation in the poverty alleviation schemes. Free education to children of benchmark disability having age group from 6 years to 18 years. So special employment exchanges are available. Special court and special punishment provisions are available as per RPWD Act. So all the facilities need to be made accessible. So these are all the entitlements which we need to ensure. If there is any violation, it is punishable up to fine up to 5 lakh and imprisonment up to 5 years. If there is any violation in actually providing service to persons with disability or kind of doing any kind of disturbance to the life of the person with disability, if it is proved guilty, then the punishment is likely to come through the RPWD Act, which amounts from 5 lakhs to the maximum and 5 years of imprisonment to the maximum. So law has a very good provision to give facilities and to protect the rights of persons with disabilities. So let us do our best and try to work together and empower persons with disabilities to live a dignified life in our society. So for any further details, you can contact us in the landline number. We have our website also, so you can contact me in the email ID also. So we are working in all working days. Now earlier it was Monday to Friday. Now in Saturday, Sunday also we are working up to 2 p.m. It's 9 o'clock to 5:30 is the usual working day. Saturday, Sundays also now we are working, and we are also providing service 24/7 service called Kiran Mental Health Helpline Service. So which is launched by Ministry before some 3 years. So 24/7 helpline service related to facilities for persons with disabilities, related to mental difficulties like there is difficult to cope up with acute stress, depression, so anxiety. So the primary counseling is being given through phone 24/7. CRC provides one of the region service. Actually, we take care of across Karnataka. Team of some 5 professionals, we take turns and we provide this service also. So ministry and the government are trying a lot to ensure people with disabilities are liberated from the vicious cycle and getting into a poverty loop. So including persons with hemophilia, it starts from issuing UDID card, and it ends up in actually like enabling them getting job, getting empowered, getting self-employment opportunity. It ranges from the health service to education service to skill development service to enabling employment opportunity service. So many provisions are there. We need to be aware of it, and we need to spread the information about the different schemes availability, and spread the information about the availability of online registration facility for UDID, online registration facility for assistive device Arjun portal, online registration facility for the scholarship issuance. Many things are in our hands now. We all have mobile phones in our hand, so we can do a lot of difference if we are using beyond our WhatsApp chatting, cheating, and Facebook activity. So if we try to little explore more in the website, like many informations are available, and we can do wonderful work in rehabilitating persons with disabilities, including persons affected by hemophilia. Thank you very much, Dr. Tamare Selvan sir, for providing the wonderful opportunity. So I thank Dr. Retired Major B.V. Ramkumar sir for immediately approving this webinar, so which is actually being useful to more than 300 people. Actually, I am seeing actually 300 active participants patiently listening and understanding all the points which were shared by Dr. Suresh Anagwadi sir and by myself. Now the next speaker is also readily available. So I thank our management, CRC Davangere and NIPID Secunderabad. I thank Dr. Tamare Selvan sir, my co-coordinator Dr. Surendra Babu sir, and Dr. B.V. Ramkumar sir, retired Major General, Director of NIPID Secunderabad, for providing the opportunity. So I thank all the participants for patiently listening. With this, I wish to sign off. Thank you, sir.
Thank you, Savabali sir, for your wonderful presentation as usual. And so actually, it's a one-day session you have covered within 1 hour. It's a great presentation. I think that it would be a very useful and informative presentation for all the participants. And thank you, sir. Now we'll move to the next session, and we are running short of time. Now it's already 5:06. Next, we are going to have a session on the session of the day, prevention and rehabilitation of joint bleeding, by Dr. Reswa K. Ali ma'am. Ma'am is basically a physiotherapist. She has completed her Masters of Physiotherapy in Musculoskeletal and Sports, and she has 4 years of experience after PG. Ma'am is currently working as a physiotherapist in a Haemophilia Treatment Center, Government Hospital, Alva, Kerala. And ma'am has many publications in national and international journals in hemophilia. And so I hope that ma'am is a out person to present the topic on the rehabilitation and the prevention of the person with the hemophilia. Yes, I think ma'am has already joined. I hope the ma'am is there. Ma'am, you can respond. Reswa ma'am, have you joined? Reswa K. Ali ma'am, have you joined?
Yes, sir. Yes. Yes,
okay,
sir.
okay. So you can start your presentation, ma'am. Yes.
Okay.
Okay, thank you. Good evening, ma'am.
Good evening. Hello. Listen.
Good evening, madam.
Good evening. Good evening.
Yes, ma'am. You can go ahead.
Okay. Thank you.
Your slides are visible. You just make it full screen, ma'am. That's it.
Okay. Let's start. Hello. Let's start.
Yes, ma'am.
Yes. Okay.
Yes, ma'am.
World Haemophilia Day is celebrated on 17th April annually. The day focused to make an effort for better diagnosis and access to care for those people who can't afford itself. The theme of in this year is Access for All Prevention of Bleed on Global Standards Care. In last year, where the theme is Access for All Partnership Policy and Progress. In a nutshell, this day focusing on educated its patients and general public. It's also emphasizing the proper treatment and care for them.
Sorry for the interruption. Could you make your PowerPoint full screen?
No, sir.
No, you just click F5. F5 in your laptop.
Yes, no, sir. I can't do it.
Okay, ma'am, you can continue. No problem.
Okay. Thank you. Talk about history of hemophilia. Why Haemophilia Day celebrated on April 17th every year? Because World Haemophilia Day was first celebrated on the 17th April 1989 by the World Federation of Haemophilia to honor Frank Schnabel's birthday. The World Federation of Haemophilia founder. Haemophilia wasn't discovered until the 10th century when people started paying attention to the disappropriated number of male deaths from the seemingly small accidents. In 1803, Dr. John Conrad Otto of Philadelphia, bringing researching Luther, who eventually concluded that the disease was passed down from the mothers to son. In 1937, hemophilia was classified as a type A or B genetic disorder. However, effectively treatment had yet to be developed up to the joints. Can you mute? Okay, thank you. And let's talk about hemophilia. What is hemophilia? Hemophilia, it is an inherited bleeding disorder in which there is a deficiency or lack of factor 8 or factor 9. Two cases of inheritance causing hemophilia. When healthy woman married into hemophilia men, that is, healthy woman chromosome is XX normally, and hemophilia men chromosome is 1X hemophilia affected, and other Y is normal. And when the byproduct is two carrier girls and healthy boy. And when the carrier girls married into the healthy men, it is going to be the final product is hemophilic boy and the carrier girls. This is the two main causes of hemophilic inheritance. And coming to the classification. The hemophilia classified into the three according to the percentage of clotting factor presenting on blood. In severe cases, first one is severe causes in percentage of blood in clotting factor on blood in less than 1%, and pattern of bleeding happening in every year 24 to 48 approximately, and the causes of bleeding in spontaneously. And next one is moderate, when the percentage of clotting factors on blood on 1% to greater than or equal to 5%, and bleeding happening per year 4 to 6 bleeds per year, and the causes is minor trauma. And mild, 5% to more than 5% to 40%, and episode of bleeding uncommon. And major causes of bleeding episode, we can be finding the major trauma surgeries like that. Next, coming to the manifestation of hemophilia. And hemophilia can affect any organ or any part in the body, that is head to toe. And joints, 70 to 80% of chances happening to the joints, especially in knee joint, ankle joint, and elbow joint. And muscles and soft tissue, 10 to 20% of chances, especially in muscles in iliopsoas and quadriceps muscles, calf muscles. And mouth and gum bleeds us in 10%, others 5%. In infants and children's, most common bleeding happening on mouth and gums because of their biting tendency. And coming to the early symptom from childhood, blue patches and bruising on skin because they are moving into the quadruped position or crouching or supine to
ma'am,
side.
sorry to interrupt. Sorry to interrupt, ma'am. Slides show नहीं हो रहे. Please show your slide, ma'am, please.
Once more, tell me, please.
Slides show नहीं हो रहा, ma'am. Slides are not working. We are on same slide.
Oh, sorry.
Your slides are not moving, ma'am.
Oh, okay.
Ma'am, shall I present from here? Yes, ma'am. We have your slides. We'll present from here.
Okay, wait. You can see the slide?
Yes, we do.
Yes.
Okay. And next one is gum bleed. And frenulum bleed, cuts and wounds which a long time. When the gum bleeds is commonly quite happening on the infants because of the biting tendency. And early symptoms, unbearable pain in muscles and joints, swelling without injury. And second picture is shown the knee joint bleeding, and the last picture is shown the calf muscle bleeding. Types of bleeding: joint bleeding, muscle hemorrhage, soft tissue, and life-threatening bleeding. Others is especially in gastrointestinal bleeds and etc. Next part in assessment. Assessment part is very important in hemophilia patients, and documentation also important. First one in personal data, and second one in history, third physical examination, and fourth one imaging techniques. And coming to personal data. History. Bleeding disorder, type hemophilia A or hemophilia B, severity, severe, mild or moderate, and inhibitor. Inhibitor means it is an immune system response to infused clotting factor concentrate, which rendered standard replacement therapy is ineffective. That time where is using the FIBA. FIBA is very costly compared to factor. And family history, family tree. Family tree, its taking is very important in hemophilia patients. And bleeding history, annual bleeding rate. Approximate annual bleeding rate it's taken is very important on documentation on hemophilia patients. Onset of first bleed, spontaneous or traumatic bleeding. And next one is bleeding target. Target joint means 4 bleeds into the same joint in a 6 months times. It's especially mainly in knee joint, ankle joint, and other elbow joint like that. Infusion history, frequency, mainly in frequency. Treatment history, on demand or prophylaxis or home therapy. On demand means treatment given at the time of clinically event bleeding, and prophylaxis, regular continuous treatment. In prophylaxis is divided into 4 types: primary, secondary, tertiary, and intermediate. And next one in home therapy. Hemophilia patients receive treatment with coagulating factors in their at the home. It mainly taken in hemophilia patients or parents. And viral screening, HIV, HBC, HBV, HCV, and others. Auxiliary aids, usage of orthosis. And next one is physical examination. When the physical examination, hemophilia patients is checking into the pain, warmth, tenderness, swelling, range of motion, loss of movement, crepitus, joint instability, proprioception, muscle spasm, muscle strength and duration, muscle, limb length discrepancy, posture, gait, neurological deficit, balance and coordination, and last one, contracture and deformity. All these factors are checking into the hemophilia patients. Next in imaging technique. Imaging techniques mainly in X-ray, ultrasound, CT, MRI. X-ray mainly finding in the finding in the bone changes like that. And ultrasound, CT, MRI are mainly checking into the fresh bleed or bleeding severity like that. And when X-ray is checking in osteoporosis, enlargement, emphysis, irregular subchondral surface, narrowing of joint spaces, subchondral cystic formation, erosion of joint margin, osteophyte, incoherence of articular bone ends, joint deformity. Soft tissue changes or findings in X-ray, synovitis, synovial hypertrophy, hematoma, joint effusion, pigmentation, tears and degeneration. Next one is very important for hemophilia, that is hemophilia scales. Hemophilia joint health score and functional independence score for hemophilia. And HJHS, hemophilia joint health score, it's especially mainly checking in bilateral elbow joints and bilateral knee joint and bilateral ankle joint. I already told that bleeding are commonly happening in three joints, that is ankle, knee and elbow joints. And others, and additional to global gait score also checking into the HJHS, that is walking, stair climbing like that. And next in functional independence score for hemophilia. This is mainly using in ADL activities, eating and grooming, bathing, dressing, chair, squatting, walking, stair climbing, up and down, and running. And next part in management. Management is mainly in acute and acute is needed to the price protocol. P means protection or pressure. R means rest. I means ice fermentation. C means crepe bandage or compression. E means elevation and exercise. And next in anti-hemophilic factor replacement. That is mainly in administered into IV. Dosage, it is depends upon the weight of the patients, and routine of bleeding 20 to 40% of factor level maintaining in blood, and the surgery and emergencies level 100% of factor level maintaining in body. Management. Pharmacologically method, that is analgesia or pain killers, pain relieving factors, medicines, and physiotherapy, counseling. Basic principles of treatment. Bleeding should be treated with a factor replacement therapy at earliest possible, within the 2 hours of onset of symptoms. Do not waiting for any appearance of treatment symptom. If any doubt, you can go into the treat. Joint hemorrhage. I already told us local applications applied acute in price protocol mainly, and controlled the pain with adequate analgesia, and administered the appropriated dose of factors, and then evaluated. X-ray is usually not indicated in joint hemorrhages, and if the symptom is persisted, repeat the dose 12 hours in hemophilia A and the 24 hours hemophilia B. The joint should be mobilized as soon as possible after the pain subside. If the symptoms and findings persisted, consider presence of inhibitor, septic arthritis or fractures. And iliopsoas hemorrhage. Iliopsoas hemorrhage is a muscle bleed. It is a very worst, and duration of recovery is very long. When the symptoms is pain in lower abdomen, groin, or lower back, and pain on extension of the hip joint. Paresthesia on the medial aspect of thigh. The symptoms may be mimic acute appendicitis. Immediately rise the patient's factor level, maintaining the level for 48 to 96 hours for the 20 to 40% in factor level on blood, and immediately shifted into the nearest hospital. Further diagnosis, ultrasound and CT can go. And next in home therapy. Home therapy means hemophilia patients receive treatment with coagulation factors at the home. Importance. Treatment quickly. Hospitalization can be avoided. Help in prophylaxis treatment. Participation in normal activities. And risk. Failure to recognize serious bleed, injury caused by inappropriate needle disposals, infection or damage to vein, failure to recognize any adverse reactions to factor concentrate. And assessment of home therapy or assessment of bleed for home, looking for movement, pain, swelling, and warmth or temperature. What to do? Reduce or stop his or her activity, price protocol, and factor concentrate. Report all joints bleed into your hemophilia treatment center. Introductions of physiotherapy. Physiotherapy is an integral part in the management of people with hemophilia. A key goal is to help maintaining mobility, muscle strength, and balance. Physiotherapy advice on safe sports and exercise. And role of physiotherapy. Physiotherapy plays a vital role in prevention or minimizing of deformity and disabilities associated with hemophilia and facilitated normal functional lifestyle. And main aim of physiotherapy. Educated people with hemophilia and their families. Advise patients about the importance of joint protection. Advice on treatment for pain and suffering. Regular assessment and monitoring joint status, and work as a part of multidisciplinary team to determine treatment modalities. And main goal of physiotherapy in hemophilia. Treatment of muscle imbalance, ensure disease of pain and increase of function, stretching to improve flexibility and prevent muscle shortening, strengthening of muscles to improve stability, postural training, correction of wrong or harmful movement pattern and joint biomechanics to prevent damage, treatment of affected or badly functioning joints. And the treatment part, first in acute phase. Acute phase is given into the first aid, that is price protocol, protection, rest, ice, compression, and elevation. Why protect? To reduce pain, minimize risk of causing other bleed, the joint itself to high risk of re-injury in first 2 weeks, and muscles in highest risk of re-injury into the first 6 weeks. And immobilization, how? Non-weight bearing for the affected limb, uses crutches and splints for lower limb, and back slap, thermal plaster, static splint. Splint is comfortable position and a comfortable range of motion, and bed rest in cases of iliopsoas bleed, and no sports activity, not vigorous activity. How long? Immobilization. Until signs and symptoms are much better, until full and easy pain-free range of motion is restored. For major bleeding, 3 to 5 days at most. Immobilization for the shortened at the time. Immobilization during serious part of the day. Example, at the school during the break period when play boys. The longer your immobilization, the greater the muscle weak. And next in ice protocol. Ice using in the affected area, 5 minutes on time and 10 minutes off time. Place the ice circumferentially around the joint area or joint. Do not place the ice directly on skin. Use towel or cloth as a barrier between skin and ice because of causing of ice burn. And uses ice before and after exercise. And compression. Slow bleeding, reduced swelling, reduced pain, limited movements of joint, use crepe bandages, not too tight because it may cause in more damage. Uses elastic type of compression bandage and figure of 8 pattern. And next in elevation. Elevation is mainly helping reinforced rest and assist in drainage. It mainly helps in reducing swelling. Next part in rehabilitation. During acute stages in joint bleed, starting with gently static muscle contraction or isometric exercise when pain allows, 5 to 10 contractions twice a day, progress to 50 contraction at the 3 times per day when the pain decreased and swelling is down. As the symptoms is improved by 50%, progressed into the next stages, that is free active exercise. Starting with the pain-free range and progressed slowly. Fewer repetitions to started, gradually progress to more, up to 50 counts. Therefore, progress to heavier resistance or weight. It is depends upon the patient's status. And next in range of motion. Active stretching exercise, holding the stretch for 10 to 50 seconds. Serial spinning can uses for the prolonged stretching. Stretching is mainly in two types, active stretching and passive stretching. Passive stretching is mainly done by the physio and active stretch is done in itself of patients. Next in stretching. Importance of stretching. Be careful because overstretching can leading to muscle bleeding. Active stretching is best. Serial spinning for prolonged stretching. In the case of joint contracture. Strength. Muscles are weaker after immobilization and rest. Some become worsted. Isometric muscle contraction from acute stage. Progress slowly to free active exercise. Inner range exercise. Movement with gravity eliminated and movement with against gravity. Resisted exercise to commence when the range of motion is at least 90%. And when full range of motion is achieved, added lightweight, less repetition, progressed to 50 repetition 3 times per day. Gradually return to sports or activities. Remember, strong muscles support and protect the joint, which reduce the risk of bleed. And last stages is weight bearing stages, and the initially or acute phases is non-weight bearing with the use of crutches and splints, and which it is may progress into partial weight bearing with partially usage of crutches and splints on during started of free active exercise, and it progressed into fully weight bearing without any support. Physical activities and sports. Why? Protect the joint by building strong muscle and healthy ligament. Improve skill, coordination, endurance, and stamina. Team spirit, friendship, and give a child a sense of personal achievement. Help restore fully activities. Which sports can chosen for hemophilia patients? Avoid contact sports, high impact sports or sports with a very high risk of bleed like boxing, football, rugby, hockey, mountain biking, squash, and weight lifting, etc. Suitable for sports activities, swimming, cycling, walking, dancing, chess, caroms, and rowing. So no contact. In second part, I told this, there is a no contact of any activities. And the last and final part in hemophilia advanced treatment for the advanced treatment, and it is aquatic therapy. And benefits of aquatic therapy, about 50 to 50% to 80% reduced on weight bearing. Water buoyancy lower the risk of stress-related injury, especially in all, and allow muscles to work their fully range of motion. The water resistant against your movements, resulting in the highest workout intensity. A protective splinting effect is created when the muscles are surrounded by water. Renew your energy level as it is released to your stress and tension. Aquatic exercise burns a high number of calories. And we are trained into the hemophilia patients training section. First part, it is a helping, first part is a strengthening technique. And the second picture, it is a strengthening of the lower back. And this is a training for the sitting balance. It is mainly helpful for the strengthening of the quadriceps, knee joints, and gluteus muscles and calf muscles exercise for hemophilia. And instructions for physiotherapy. Each exercise hold for 10 seconds, that is a count for 10, following by 5-second relaxation and repeat. Each exercise start with a minimum weight, gradually progressed by increasing weight and number of repetition as decided by an experienced physiotherapist. Stop exercise if bleeding occurring. Consult your physiotherapist regularly for monitoring and modifying your exercise program. Summary. Physiotherapy is an important part in hemophilia care. The healing process will occurring with a good rehabilitation technique and is a slow progress. Work as a team with a physiotherapist and comprehensive care team is adventurous to the PWH. And my conclusion, and what this day demand to us, promote the importance of taking coordination and concerned action to achieve the World Federation of Hemophilia vision of treatment to all. Draw attention to the key issue and put hemophilia and bleeding disorder in the spotlight. Thank you.
Thank you, Dr. Raslari, ma'am, for your wonderful presentation on the rehabilitation and the prevention of the joint bleeding for the person with the hemophilia. And now it's time for discussion. And participants, if you have any doubt, you can clarify your doubts here. And you can drop your questions in the chat box. And we have shared our feedback link in the chat box. And I request all the participants to fill the feedback link so that you will get the e-certificate through email. And any doubts you can ask now. Madam will be available for another 5-10 minutes. Any doubts from the participants? And let me check the chat box if there is any doubt. Ma'am, Rasla ma'am.
Yes.
Hello.
Yes.
Yeah, someone has asked about the, it's not relevant to our topic. It's what is the lifespan of a hemophilia affected person? Lifespan, they're asking for the lifespan. I think it depends on the severity of the bleeding.
Severity of bleeding and treatment.
And treatment. And then
factor and physiotherapy is a major part in hemophilia patients' lifespan decided.
Okay. Now, see if there is a problems like the life-threatening bleeding, like intracranial bleeding or intestinal bleeding,
yes,
GIT bleed, all these will increase the fatality in the hemophilia patients.
Yeah.
Yes, ma'am. And one more question, ma'am. We have electrotherapy modality for pain relief.
It's a
what
mainly,
would you suggest?
TENS. Arthritic pain we have mainly uses in TENS with a lower intensity.
Okay. Yes, ma'am. There's one more doubt. What are the absolute contraindications in hemophilia patient? In the physiotherapy point of view. Absolute contraindications for doing physiotherapy. I think it's acute bleeding, no? Acute episode of bleeding then. Contraindications, ma'am. Contraindications.
Contraindications for?
For physiotherapy.
For physiotherapy.
In hemophilia.
Yeah. It's mainly in using of hot pack.
Heat modalities, no?
Heat modalities like hot bags is mainly contraindicated in hemophilia patients because it's happening in vasodilation.
That will aggravate the bleeding, I think.
Yes, it's aggravated in, yes.
Especially during the acute phase of bleeding, if you use the heat modalities, that may aggravate the bleeding instead of controlling it.
Yes.
Someone has asked ultrasound can be used. Ultrasound therapy can be used for joint swelling.
Yes, yes. It is mainly using in hello.
Yes, ma'am, you're audible. You're audible.
1:8 mode. Ultrasound mainly used in 1:8 mode.
Oh, you mean the pulsed mode?
Pulsed mode. And its
Okay.
intensity is very less and may 4 to 5 minutes duration of use ultrasound.
Okay, okay, ma'am. So can we use IFT for pain relief?
No, it is producing in more vasodilation effect. So we are also using in TENST for pain relief in modalities, pain management.
Okay, I think there is a question to Sabhapati sir. Sabha sir, you are there?
Yes, sir. Yes, sir. Very much there, sir.
There is someone asked some certificate is not
Yes, sir,
given
I'm
to
up.
hemophilia. Yeah. Have you seen that, sir?
Not seen the question actually. Like, certificate related issues. So, medical board need to be approached. So, after enrollment in the UDID website, the acknowledgement need to be downloaded with
sir, good evening, sir.
Supportive document.
Sir, good evening.
Good evening. Good evening, Sandhya Rani, madam. Yes.
Certificate not given, sir. Sadram certificate. All of you suffer for that certificate. Government not issue, sir.
Yes, madam. Actually, medical board is responsible. Government is supposed to issue as per 2016 RPWD Act.
Okay.
As per RPWD Act 2016, each district must have a medical board. Each district must have a medical board comprising specialty doctors, orthopedicians, neurologists, hematologists, or pathologists,
there is no
psychiatrists.
Doctors, sir. There is no that type of doctors. For
Hematologist or pathologist.
No, sir, no.
Blood bank is there? Blood bank.
Sir.
Blood bank medical officer is also responsible. Blood bank, government blood bank medical officer. You approach your district hospital superintendent with the UDID registration document. UDID registration document is downloadable from the swalambancard.gov.in website. So, application need to be done. It is a self-registration portal. Application need to be done. Downloaded acknowledgement along with Aadhaar card, along with any other medical document which is actually quoting that person is having hemophilia, diagnosed with factor 8 deficiency or 9 deficiency, any medical document. Along with the document, you need to approach the district government hospital medical superintendent or the RMO, residential medical officer, who is head of the district medical hospital, district government hospital, and you ask them to actually review the online registration acknowledgement which you are submitting, and you ask them to certify it in online. It is their duty to do it. If they are not doing it, you give an application, take acknowledgement from them. You are giving application and take acknowledgement from them. Wait for some 1 month, 2 month, 3 month time. Nothing is happening. You take the acknowledgement, the written acknowledgement to the DC, district collector. So you appeal the district collector. In my district, for a person affected by hemophilia, medical certificate is not being issued. So it must be issued. As per 2016 Act, it is the duty of the medical board to assess and issue the certificate. They are not doing it. So please intervene, sir. Like that, you give a request letter to the district collector. So district collector will definitely direct the district hospital to look into it.
Okay, sir. Okay. Every district, this is problem is there, sir. Every district.
Yeah, people don't talk. People don't even discuss. That is why 20% only is the disability certification coverage.
Only mentally, physically, hearing impairment, Sadram certificate issued.
Those things and all 50-60% coverage is there actually. But for hemophilia, only 20% coverage. Why 20% coverage? Because doctors themselves, they don't know, and there is
There
no
is
board.
no awareness, sir. There is no awareness for doctor, medical officers.
Your background, madam? Your background, Sandhya Rani, madam, your background?
My IRP special educator from Yadadri district, Telangana.
Okay, very good, madam, and you are very outspoken. So, like you, special educators need to actually approach the health department and facilitate the process. So,
our collector also very nice and involved all types of issues.
Yes, madam. Yes, madam. Thank you for asking the question. I'm sure, like with appropriate documents, you appeal the authorities, they will do the needful. Thank you very much, madam.
Okay, sir.
Hello, sir. Can we be provided with the recording of the lectures?
A recording is being done.
Sir, the videos where it will be available so that we can go back and see the lectures.
Yeah. We can share you the YouTube link because it is going on YouTube live also. So we'll be sending you the YouTube live link, so you can watch through YouTube. Okay, using that link.
Okay. Thank you.
Okay.
Hello.
And that's what. Yes. Carry on.
I have a question regarding hemophilia of patient with children. Type of professional to management hemophilia. Question 1. Question 2 is what is condition? What is stage to risk care? Please give me reply my some.
Rasla ma'am, you can answer for that.
My question is types of professional to management hemophilia, children, anyone. Second question is what is stage to very sensitive to hemophilia.
Rasla ma'am, you're there?
Yeah.
I'll tell you. Actually, hemophilia, Dr. Suresh clearly told during his sessions, it is a teamwork which is very important in the management of hemophilia. Starting from a medical expert like a hematologist or the orthopedic surgeon, and then the health professionals like a physiotherapist, occupational therapist, as well as the nurse, even pharmacist, and then psychosocial worker, psychiatric social worker. So all these team is involved in the management of hemophilia. So the teamwork is there, but the other issues, if you see with the hemophilia management, so other issues are there is. So there is a lack of availability of all these professionals under one organization. Okay, that is the limitations that we are facing, and hope in future all these issues will be addressed. And the main thing, another thing is the psychosocial issues. It's also common among the family members and also the affected persons with the hemophilia. So these are the main barriers to address the complete need of the rehabilitation of the person with hemophilia, and also the cost of the factors, the factor replacement therapy. What Dr. Suresh told, that cost of the factor is also a important factor, is a barrier for this hemophilia management.
Sir, my question is specific only compulsory professional the management hemophilia. These are team. These are lengthy process. OT, doctors, hematology. These are a team. But minimum professional is important. Professional. This management is guideline first. And this is my this question.
Yes, sir. There is a guidelines by the World Federation of Hemophilia. You can go through that. The clinical management guidelines are there. So what is the role of physiotherapist? What is the role of a physician? So it is clearly mentioned in that. It is released by the World Federation of the Hemophilia. So you can refer that, and you can take the knowledge from that.
Okay. Thank you.
Okay. Any other doubts? I think the time is going to be 6 o'clock, and someone asked about the aqua therapy. I think Resla ma'am is there.
Feedback performer link, sir.
Yes, yes.
Please send.
Sir, yes.
Yeah, there, ma'am. Someone asked about the hydrotherapy, ma'am. Aquatic therapy.
Aquatic
Can explain
therapy.
about it.
Feedback performer. Sir, please send again feedback performer.
Okay, so we'll send you.
What
Okay,
is
thank you.
what is the question about aquatic therapy?
It's a what about aquatic therapy? At what extent it is helpful?
It is about the 50% to 80% reduced weight bearing on aquatic therapy. Water buoyancy lower the risk of stress-related injury, especially in joints, and allowed the muscles to work their full range of motion. Water resistance exercise against your movement, resulting in a highest workout intensity. A protective splinting effect is created when your muscles are surrounded by water. Renews your energy level as it is released your stress and tension. Aquatic exercise burns a high number of calories.
Madam, I am asking about the preventive steps in like aquatic therapy. Can we really, it's helpful for the maintaining range of motion?
Yes, sir.
Like,
Yes, sir.
and
Yes, sir.
like prevent the contraction.
Yes, sir. It is helps to maintaining or improve the range of motion. Since normal walking or normal range of motion exercise are also helping the muscle strength and like
So
that.
why we should go for the aquatic therapy? If normal walking is helping, why we should go for the aquatic therapy?
In land therapy, every exercise.
Okay. I'm just asking one question. Is aquatic therapy is useful at what, like?
At what at?
At what extent? At the age group of 13 to 20 years. I have 15 children of hemophilia. So I am making a protocol for them also. So if your guidance will helpful.
What age of children?
13 to 20, madam.
30 to 20. Okay, they are also have treated in. They are also helpful or using or aquatic therapy. It's very helpful. It is mainly just a walking exercise in water. Different type of walking exercise, like different ways of support and single leg standing, squatting. It is also improve their muscle strength and muscle power. They are all, and it is helping into the lower chances of bleeding in that target joints or any area of bleeding.
Okay, madam. Thank you.
Okay.
Thank you, Dr. Riswa ma'am, for sparing your time with us. And we had another wonderful webinar on this World Haemophilia Day. And so we would like to thank all the participants for your patient listening for all the 3-hour sessions, starting from the medical aspect and the government schemes and benefits and the rehabilitation aspect of the hemophilia. So I hope you enjoyed and it was very informative for you all. And looking forward to your participation in all our forthcoming webinars and the programs by CRC Davanagere. And we are always grateful to you. You only making all these our programs a very grand success. Actually, we were planning this program for 1 hour only with the rehabilitation aspect, and our ministry was very much impressed with this topic, and they wanted to convert this a 3 hours program with inputs from the medical and as well as the government schemes and benefits. And once again, I would like to thank you all for your participation, and I would like to thank the program coordinators, Sabhabadi sir and the Babu sir, for their coordination and the communication with our head office. And also I'd like to thank our director of ECAting, Sri B.V. Ramkumar sir, for his constant guidance and support to conduct such programs throughout this year. So thank you one and all. Thank you, Rasula ma'am, for your wonderful presentation. And Yes, ma'am. So I would like to thank Dinagar Viswam sir, and sir has suggested your name. Actually, first we upload sir. Sir was busy with other program. Then sir recommended your name, and so you just means we had you presented nicely, and it was very informative, and practically you taken the sessions. And thank you, ma'am. Thank you for your presentation. We looking forward to your presentation in our forthcoming webinars.
Thank you, sir. Thank
Okay,
you,
ma'am. Okay,
Tulasi.
ma'am. So, okay, ma'am. So, thank you all, and I hope all you might have received your e-certificates by submitting your feedback form link. And thank you, and see you in our next another informative webinar. Thank you, one and all.